next speaker is again back to Dr. Monzr Almalki to give us a talk about post-transplant cyclophosphamide as a new standard therapy.
So this talk will be about the new standard of care in GVHD prophylaxis. And those are my disclosure again. And I like to start with this always as a reminder of this old drug that we used to use for other indications. And this is a activation and metabolism circle that goes on in the liver with using of cytochrome P450. And the results of this reaction ultimately is the toxic acrolein that convert to phosphoramide mustard. And this derivatives is the reason for the cytotoxicity with this drug. This type of approach is mostly specific for G1 and S phase in the cell cycle. So it is specifically targeting a very rapidly proliferating T cells. And from the other hand, we think that having aldehyde dehydrogenase, which is the inactivating enzymes in the stem cells and in the Tregs, are the important aspect why this is not toxic to the stem cells and why it causes decrease in GVHD. In this study, it goes back way long to the 60s, where this concept was used in the skin allografting. And as you can see from this graph here, patients who have graft followed by cyclophosphamide on day 3 and 4, up there on the top, had the longest time of surviving of the graft. And this is the first study that showed the concept of the timing of this drug that is important in its approach. And then later on in 60s and 70s, the Japanese group also described the cell followed by cyclophosphamide process and how this can induce tolerance for in a mice model. And later, in the end of 90s, beginning of 20, this process was explained very well by the Hopkins group and followed by the NIH, the Kankeri lab. And in this schema, we all know about this, and I'm just going to review it for you. Activated T cells that are presenting those antigens that are presented by the T cells from the recipients are proliferating in a rapid rate up until day 3, when the cyclophosphamide arrive and either eliminate the active T cells or, as later on described, marginally deactivated, producing some of those T cells that are going to have a balance between Tregs and Tcons, and this balance is what's going to determine the GVHD risk that the patient will have. Later on, some of those will be also deleted in the thymus, hopefully deleting all the self-recognizing T cells, producing hopefully state of tolerance for those patients. This was first time shown in a clinical trial between Seattle and Hopkins when the study started, and day 3 cyclophosphamide, day 4 was added later on, and as we can see, that reflected on the chronic graft versus host disease rate. And the study was very successful. It was a concept proof of concept, and it pointed out to the risk of relapse that happened in these patients. And if you see in the first curve here to the left, relapse was close to 60% long term. But nevertheless, it shows that this process is safe and possible in human. Later from that, the CTN group took this into the match donor setting after tons of data in the haplo setting and compared those 3 different regimens together against a contemporaneous type of cohort that was done in CIBMTR against TAC methotrexate. And finally, they found out that the winner from this comparison was the post-cyclophosphamide, and this was moved to a randomized phase 3 study, CTN 1703, when PTCy was compared head-to-head against tacrolimus methotrexate. In this study, which was published last year, post-transplant cyclophosphamide was superior and caused a good 20% increase in the grafts compared to tacrolimus methotrexate. This was mostly due to decrease in the severe acute graft versus host disease and chronic graft versus host disease. Survival was numerically different, but the statistical value was not met. And further long-term survival follow-up might show different things. At the same time, in Europe, there was another study which was done by the Hoven group and was comparing post-transplant cyclophosphamide with cyclosporin in this study. Against cyclosporin when MMF in a patient undergoing transplant, non-myeloablative transplant from matched sibling and matched unrelated donors. This was a 2-to-1 randomization, and as you can see, the same results showed. And in this study, they compare also the outcome based on donor, and there was no difference in MUD versus sibling donor. Later on, some studies were published to show that this is possible also in the myeloablative setting in the younger patients. And this was started also in Hopkins, where they did this PTCy to Cy type of study. Later on, they found out that this 2-Cy type of things, the total dose of 200 milligram per kilogram is toxic, causes more VOD, and hemorrhagic cystitis was in the range of 10% as grade 3 and 4. And this led to change that to flu-Bu, which is adapted everywhere else. Other groups used FTBI, thinking that this might be less toxic than chemotherapy. And then the group from Minneapolis did this study with 125 patients in leukemia, lymphoma, CML, and some myeloproliferative disorder. They did, couple of different regimens, but the most common one was FTBI. There was some matched donors and mismatched donors in this, and most of the grafts were peripheral blood. But ultimately, they showed good results with similar type of outcome decrease, and they compare it with internal cohort. And they found out that GVHD is less, chronic GVHD is less, and grafts is better. This is in this study, there was no longer-term follow-up, but then later on, they published that this was concerning for relapse. They had significant relapse in PEDS was up to 50%, thinking that this might need to be optimized a little more. And in City of Hope, we do fludarabine FTBI. We add 3 days of fludarabine at 30 milligram per meter square to the same regimen that the Minneapolis people did. And we published this data on this, and we didn't see the same relapse risk. We actually went ahead also and compared between haplo and mismatch unrelated donor, where those are the 2 donors used in the study, and we showed that you use this regimen with the post-transplant cyclophosphamide, HLA mismatch is not really an issue. Relapse risk at 2 years was close to 15%, which is very promising. We went ahead and also thought of this pilot study where we increased the intensity of conditioning. Every time we see less relapse risk, and seems like the conditioning is related to that. So we increased the conditioning regimen and used something called total marrow and lymphoid irradiation, which was pioneered 10 years ago in City of Hope, and we have a lot of data on this. But we combined that alone without chemotherapy with the cyclophosphamide, and the dose here is 2,000 compared to your regular FTBI, which is between 1,200 to 13.5. And as we can see here, very promising study. I mean, we had very high-risk ELN patients in this study, and relapse was only 20% at 2 years. The study is accruing, and we have like up to 50 patients now, and hopefully we'll report larger samples soon. This is the CTN 1301 that we all are aware of, and this shows that in the myeloablative regimen setting, when you are using T-cell depleted product, you have lower survival. But when you're using TAC, methotrexate versus post-transplant as a single agent in a bone marrow setting, you are having the same outcome. Just note, looking at the curve number E in the bottom of the slide, you will see that the PTCy relapse risk is lower numerically. Again, statistically is not significant with that short follow-up, but that concept is, when you optimize your conditioning, you might have better relapse with the PTCy, and the idea of PTCy increasing the risk of relapse is not valid. I'll just go over a couple of studies about the common complication from this platform. Hopefully this will be helpful for practicing physicians. First, we looked at the CRS risk in this platform, and as we know with peripheral blood, you see CRS a lot. You guys see this all the time. And we found out that most of the people with haploidentical transplant from this study had CRS. Luckily, only 10% had the grade 3 and 4, and those are the ones who underperformed with a higher non-relapse mortality on the curve. And we looked at the factors that cause higher risk of CRS in this population. We find out that patients who are older, reduced intensity, having active disease, or having more mismatches are more likely to have CRS, and risk of mortality will be higher. Also, we correlated the CD3 composite of the graft with the risk of CRS, and we find that higher CD3 will be important for you to be careful with. But as we know in the lab, it's difficult to cap CD3 real time, so we use CD34 as a surrogate to cap the product. Later on, we looked into use of tocilizumab to help with the CRS, and we find out, as you see in the yellow curve here, significant increase in chronic graft-versus-host disease when you use tocilizumab. Yes, we get them through the first 5 days, but then, at 2 years, they have 65% percent of graft-versus-host disease, and that defeats the purpose of using this platform. So we recommended from this paper is that if you have grade 3 and 4 where your mortality is high, go ahead and use tocilizumab, while the common ones, grade 1 and 2, that does not affect your survival, should be treated supportively without interfering. Hemorrhagic cystitis is another reason for a patient to have bad morbidity during the transplant with the cyclophosphamide. And we looked back, and the way that we prevent that is by using hyperhydration. With this approach that we use in this cohort, we showed that 30 to 40% will have some form of hemorrhagic cystitis. Again, mostly grade 1 and 2, and grade 4 was non-existing, as you can see here. This was split to chemical versus viral, and there is a lot of differences between. I refer you to look into this very useful paper. This old abstract, it was abstract, we never published it because it was right before letermovir came, and it didn't help a lot, as everyone is using letermovir in the United States at least. And we thought, we reported that the risk is close to 70% that patients with haplo getting PTCy will get CMV reactivation. That this was mostly transient, was treatable. There was no effect. It was not affecting the outcome, but mainly, the risk for this was recipient CMV seropositivity, which we all know about. So nothing new in this. And now with the letermovir, we are reporting better outcome, and the CMV reactivation with the use of letermovir is down to like 15%. Another complication that we need to be aware of is the cardiovascular events, and this was published by the French group earlier in 2021. And as you can see, they reported that most of the early cardiac events are either pulmonary edema or a drop in ejection fraction. They did not describe what kind of drop. It was symptomatic, not symptomatic. Is it causing problem? How was it found? But a drop of ejection fraction as well as pulmonary edema were the most common ones. There was no increase in arrhythmia, no pericarditis, and no acute coronary artery disease. So mostly those two items. And when they looked at landmark analysis, And they analyzed the outcome for this patient. Patient who scored on early cardiac event had worse survival. They went also and looked at the factors that patient will have cardiac event with the post-transplant cyclophosphamide type of therapy, and they found that older patient receiving sequential conditioning using pre-transplant cyclophosphamide, history of cardiac disease, anthracycline dose, all of those risk factors were associated with higher risk of cardiac event. We looked back because pulmonary edema was the main thing, and we thought that this might not be the cyclophosphamide itself, rather the hydration that the patient gets. And we looked at something called fluid overload in the setting of cyclophosphamide, and we find that literally everyone got some form of fluid overload. Luckily, again, the grade 3 and 4, which are the ones that impact the outcome, were only in the range of 8%. And as you can see from this curve, we see that increase in weight was early an important predictor for you to prevent this from happening. Again, the green is showing increase in non-relapse mortality. That's only the 8% of the patient who had the severe grade 3 and 4 fluid overload. We looked at the level of tacrolimus after PTCy, and we thought maybe with this study we could identify the best level to target when you use post-transplant cyclophosphamide. And in summary with this, and due to the time, I'm just going to say that higher than 10, level from 4 to 10 was the best. Higher than 10 was associated with increase in relapse. We looked at MMF dosing as well, and as we know, we cap at 1 gram 3 times a day, so different patient with different weight will have different milligram per kilogram a day. So we split those patients to 4 groups, and we find the same thing. Excessive amount of MMF caused increase in relapse, and that was a very important point. There was another CIBMTR paper showing increase in infection with MMF. So some people argue that MMF is really needed in this platform. So we have a new standard of care. How can we build on this?
2 minutes,
and what is
please.
the best? Thank you. What is the best combination that we could do? Looking at this graph from this paper, review paper, we see that there is multiple levels where we can interfere and add something to improve upon the standard of care we have. Having a good regimen, avoid tissue damage and antigen presentation might be a point. Inhibiting the antigen presentation by bortezomib or abatacept could be a point. Using JAK inhibitor or maybe specific IL-12 or 23 inhibitor could be a point. And also lastly, maybe using alpha-4 beta-7 integrin antibody could prevent the T cells from migrating to the GI and cause problems. So those multiple studies that are shown here, early and good results on different type of regimen. This is with bortezomib without calcineurin inhibitor, and we could show here that GVHD rate was good. This is the use of abatacept in NYU program. They have a very nice data combining PTCy with abatacept, and this is an important paper also to look at. We have a clinical trial that is close to accrual, and hopefully we'll report the data soon using this novel JAK inhibitor to type of suppress inflammation everywhere and combined it with PTCy and short-term tacrolimus. And results are very promising. I'm waiting for follow-up, and we will report it hopefully next year. We presented this data before some time ago now, and we showed that natalizumab, which is an antibody against alpha-beta integrin that could prevent the lymphocytes from migrating to GI, did not help patient with acute GVHD treatment, but we thought that maybe this will be a good approach for prevention. And we have an ongoing study using vedolizumab, which is a second-generation drug, ongoing now with the PTCy. Again, looked at sirolimus versus tacrolimus in the PTCy setting, and we saw that sirolimus is a very good alternative to tacrolimus. Only thing you lose is 1 day of engraftment. Otherwise, all the outcome were the same. So patient with possible neurotoxicity, nephrotoxicity, sirolimus combination with PTCy and MMF would be an excellent alternative. Also, last study I would talk about, which could be optimization through using cellular therapy with post-transplant cyclophosphamide. In this study, we are using CD4 T cells that are infected with lentivirus, introducing IL-10, which will help the CD4 to present a Tregs type of properties, and delta NGFR, which will help with purity and selection, and also target tracking afterwards. And we thought that after cyclophosphamide infusion of those cells could also impact GVHD in the future. This is like a dose escalation type of study, and it's ongoing. Thank you.
Thank you, Dr. Almalki. It was excellent overview of PTCy. And unfortunately, we don't have time for questions. We can defer the questions to the end of the session, and we can have the